Hello. Hello, everyone. Welcome to this webinar. This is an Envisioning California speaker series. It's on California's implementation of the Affordable Care Act, how Medi-Cal expansion has impacted healthcare access and health status for low-income Californians. And we're very excited that you're joining us. Before we start, my colleague, Rotzi Hernandez, who heads up our Legischool program, will go over some webinar housekeeping issues. Rotzi? Well, oh, there she is.
That. All right, so thank you all for joining us. My name is Rotzi Hernandez, and I am the director of Legischool. So just going to do a few housekeeping for everyone. So your camera, microphone, and chat is off, so don't be alarmed about that. If you need closed captioning or subtitles, just click on the closed captioning subtitles on the bottom, and then just enable the live transcript so you can see that. There will be Q&A opportunities throughout this event, as well as a dedicated portion towards the end. So if you need to use that function, just go ahead and click the Q&A button at the bottom. So the questions are confidential, so you'll submit it and you won't see it on the list, which is perfectly fine. Once you submit your question, I can guarantee you we are seeing it, and then we'll be curating those during the event. This event is being recorded, and you will all receive a recording of this event on Monday, January 31st. And lastly, towards the end of this event, I will go ahead and put something in the chat, which is the event the post-event survey. So it would be great if you could fill that out. It helps us get feedback, and it helps us improve our event in the future. And once again, thank you for being here, and I'll pass it on to Leonore.
Hi, I'm Leonore Ailing, and I'm the director. Oops, let me see here. I'm the director for the, somehow I see Ted. Okay, well, in any event, I'm Leonore Ailing. I'm the director for the Center for California Studies. We're located at Sac State, and we're all about California state government. We run programs for young people who want to work in state government. We run programs for high school students to learn about state government. And we run research programs that look at the policy issues that state policymakers grapple with. And so today's program is about that research piece. It's about what happens when the state policymakers, and by this I mean like the governor and the state legislature, decided to make more low-income Californians eligible for a government-sponsored healthcare program called Medi-Cal. Our first presenter is Natalie Schwehr, and she's a senior research associate at the State Health Access Data Assistance Center at the University of Minnesota School of Public Health. And her research interests include healthcare equity, access, and quality. Her experience includes quantitative evaluation of health policies, including a range of data sources, including survey data, administrative claims data, and decision analytical modeling. After Natalie's presentation, we'll get to hear from one of the people that worked on that original expansion. And we're very lucky to have him here, Scott Bain. I'll introduce him when he speaks after Natalie's presentation. But we get to sort of hear from someone who was sort of at the table as these decisions were being made. And I'm very excited about that. After that, we'll have a Q&A. But this whole event started with an article in a journal that we helped to publish along with faculty from Sac State. And so it's called the California Journal of Politics and Policy. And I'd like my colleague, Ted Lasher, who's a professor emeritus of the Department of Public Policy and Administration at Sac State and the managing editor of the California Journal of Politics and Policy, just to say a couple words about the journal. Ted?
Thanks, Leonore, and glad to see everybody. So as Leonore indicated, I'm the editor of the California Journal of Politics and Policy, and we've taken this over for about the last year and a half. And we're real proud to have that here at Sac State and to have the Center for California Studies administer it. We look to present work that is interesting and rigorous, like the work that Natalie has done, but that often has very clear, relevant policy implications and is a practical benefit and use for policymakers and advocates in California. So we're very proud to feature this type of work. And I want to tell people in the audience that if you've got work of a similar quality that you think might be appropriate for our journal, please contact me, because I would really like to consider it. So thank you. And I'm very glad to be here and welcome you all to the event.
Okay, great. Without further ado, Natalie.
Thanks so much. Gonna pull up my slides here. And let's see, trying to make it get into a slideshow, hopefully. Does that look pretty good? All right, so as we mentioned, going to be doing a presentation on our recently published article from the California Journal of Politics and Policy. And so that's what I'm going to be doing a brief overview of that today, acknowledging the California Healthcare Foundation for funding for the project. And starting with some background on the ACA. So one of the big goals of the ACA was to improve access to health and health insurance. Some of the aims or the policies with the ACA were more towards moderate income families, such as the federal subsidies and marketplaces. On the other hand, the expansion of Medicaid at the state level was really designed to help low-income families. So just a little bit of background, Medicaid is very important for low-income families, both in terms of financial stability, as well as access to healthcare and hopefully supporting health outcomes. So due to a 2012 Supreme Court decision, the Medicaid expansion was optional for states. So that wasn't the original idea of the policy, but that's how it turned out. And as researchers, we see that as creating a natural experiment. So it's not a perfect experiment. It's not definitely not randomized, but we do see two different groups that we can compare: expansion and non-expansion states. So many studies have used what's called a difference study design. Our paper has more detail on the methods, but just a simple image to kind of show what we're looking at. We're looking at it before and after, and then two different groups, what we think of as a treatment group and control. And so looking at this image, what we'd be interested in is the difference between the blue line and the dotted blue line. So of course the paper is a lot more methods detail, but that's the idea of what we're looking at here. In terms of California, that was definitely considered an expansion state, expanding Medi-Cal. Generally considered more of a moderate expansion state because there was some partial expansion prior to 2014. That said, 2014 remained very important in terms of increasing coverage for Californians. And that's when 2014 is when we kind of consider generally when the ACA was implemented. And aside from those policy changes to increase access, I think a really interesting thing is what's called a welcome mat effect. So where we saw increased enrollment, for example, in children, many of whom were probably eligible before the ACA, but some of the changes, including having enhanced navigators and support for that, more outreach, that also leads to increased enrollment. So I think that finding from the ACA research is important to keep in mind always when we are thinking about targeted policy changes. And as much as the eligibility is obviously essential, sometimes the outreach is also necessary to actually get people enrolled once they are eligible. So briefly summarizing some of the national studies of the ACA Medicaid expansion. This is a pretty substantial body of literature at this point, and with very consistent evidence that the ACA did increase health insurance coverage, which is what we would hope and probably expect. Also pretty supportive evidence for the Medicaid expansion, improving access to healthcare and affordability. The evidence is a bit weaker for health outcomes, and that's mainly because it's harder to study. Of course, we do really care about health outcomes for population health as well as health equity. It's just a little bit harder to find data that includes what you need to look at that. And other than the general importance of health, one reason it's really important is that low-income adults have been found to experience worse health and higher risk of death, both general mortality as well as risks of death related to treatable chronic illnesses. So Medicaid can be considered a possible policy or way to intervene and address some of these social factors and health outcomes. So looking at California in particular, the Medi-Cal expansion, as we mentioned, did lead to historic gains in coverage. Previous studies have found that race and ethnic disparities in access to healthcare persisted, which is probably not hugely surprising since we know these are really challenging social problems. But it's still promising that we're seeing improved coverage. And previous California-based studies had not looked as specifically at self-reported health and physical and mental health for low-income adults. So that's what we were, one of the big things we wanted to look at in this study. And so setting up our study, one of our aims was to look at the expansion, looking at healthcare coverage, as well as access, and also the health status and affordability. Low-income Californians, looking at adults, especially childless adults, 19 to 64, since those older adults probably have Medicare, looking at incomes below 100% of the federal poverty guidelines. And we also aim to describe disparities post-ACA, especially by race, ethnicity among childless low-income adults. So I'm not going in detail into the methods here, but our data was a federal survey data source called the Behavioral Risk Factor Surveillance System, looking at 2011 to 2019. So the 2011 through 2013 we use as our pre-ACA period, and then we also had 6 years of data, 2014 to 2019, as our post-ACA comparison period. It's nationally representative data, so that allows us to use the non-expansion states as the, basically a control group in our study, using multivariate analysis to attempt to account for the differences between the groups, since it's not a perfect randomized study. A strength of this data is that it includes health status as well as information and healthcare access. So we had 7 different outcomes. In addition to coverage, we had usual source of care. The affordability was queried as whether people could not see a doctor because of costs in the past year. And then we also had 4 different measures relating to health status, both general self-reported health, as well as measures deriving from some measures about unhealthy days. So we looked at whether people had 14 or more unhealthy days in the past month, looking at physical, mental health, and then a combined physical or mental health measure. So I'm going to highlight just a couple of descriptive results, especially relating more to the health disparities and results by race, ethnicity. So I'm going to look at health insurance coverage. Here I'm focused on childless, low-income adults in California. And these charts show the pre-ACA and the post-ACA for the white childless low-income adults and the non-white. So what we're seeing is in the post-ACA period, clearly both groups are gaining, which is great. The concern here is that, we also see that the orange bar, the white population, is stronger in health insurance coverage, both pre-ACA and post-ACA. And in fact, here, descriptively, the white adults actually had a slightly bigger percentage point increase post-ACA. So it's great that these groups seem to be benefiting from the policy changes, but we're not really closing the gap in access by health, for coverage by race, ethnicity. So usual source of care, a little bit different story here, and one that's kind of promising. So that's why I was highlighting this measure. So again, we're looking at pre-ACA, post-ACA for childless low-income adults. And here we are again seeing both groups are improving post-ACA in terms of descriptively. So just looking at the overall rates for those populations of who's reporting that they have access to a usual source of care. And here we're seeing for the white adults had about a 5 percentage point increase, but the non-white adults, the darker blue bar, had over a 10 percentage point increase. So that's a pretty big jump, and especially positive because it's actually closing some of that gap in access. Moving on to the model results, the multivariate analysis. So here we're breaking down the rows are different outcomes, and then the columns are looking at these analyses for different population groups. So every cell is a different model here. Starting out with our measures of healthcare coverage, affordability, and access. And well, first of all, in the top row, we're seeing everybody having significant improvements in coverage in the multivariate model. So that's great. Noting here that the childless adults, the second column, we are seeing a bigger magnitude of improvements compared to the first column, all adults, which does fit with the policy change. Childless adults were more likely to gain eligibility since that group had less eligibility generally before the ACA. That was one of the big goals of the ACA. So this fits with other studies, and you know, it's expected, but it's also great that the full population of low-income adults was still seeing significant improvements in coverage. So the second row here, affordability, here we are seeing that the white childless adults had pretty substantial increase, over 8 percentage points. Non-white population was not significant in that measure. I do think it's important to look at some of the limitations in that measure, as important as affordability is. And it's great that with survey data, we are asking people directly about their experiences. There's also a little bit of a challenge in that some of the most vulnerable groups might face such large barriers to care that they might not report foregone care. So the results we're finding here do fit with some, for example, a 2015 study with the California Health Interview Survey, which found that compared with non-white adults, the white adults were both more likely to report a usual source of care and also foregone care, that they needed more care. So it's kind of one of those things where you have to perceive that you wanted this care or needed it in order to report that you didn't get it. So I think that is something always important to keep in mind with the affordability measure in particular. And then also highlighting, which fits with our basically what we probably would expect from the descriptive results, where we saw a pretty nice jump in having a usual source of care for the non-white population. Those results were significant in the multivariate analysis, supporting that. So that was interesting that's the one measure, I think, where the non-white adults saw a significant improvement post-ACA, and then the white population did not. So moving on to the health status measures and unhealthy days. Let's see. So what I'm highlighting here is that for frequent mental distress, that is the health status measure where we saw some significant improvements post-ACA across the board. So that is definitely interesting, especially these days concerned about behavioral health and all that type of thing, and seeing some pretty notable improvements here in frequent mental distress. Also seeing a lot of other significant changes in this table. I'm not going to go through all of it, but for the most part, we are seeing improvements in self-reported health overall. And we also saw improvements in the combined measure when we put the physical and mental health together. Did not see so much gain in terms of just the physical distress measure. And moving into a summary. So one of the biggest takeaways is that we're finding that the Medi-Cal expansion did benefit the target population of low-income adults, and especially the childless low-income adults. We saw a lot of positive, encouraging results across our measures. So we had 7 measures total and saw good results for nearly all of them. The physical distress, not as much, but seeing significant results, for coverage, the affordability, which I'm also calling foregone care, having a usual source of care that can also be called having a usual provider, doctor, or nurse, overall health status, as well as mental health. And in terms of population subgroups by race, ethnicity, we were seeing improvements for both white and people of color, childless adults. And for the whites, in a larger number of measures, in 6 of 7 measures, we saw significant improvements, but we weren't seeing worsening for any of these groups. And people of color had reported significant improvements in 3 of the 7 measures in the multivariate analysis. And there were a couple measures, health insurance coverage and mental health, where we were seeing improvements across the board, across the different populations that we looked at. And so an overall takeaway, again, this purpose data, one of the great things about it is that we have some self-reported measures relating to health status, and these results are encouraging that the improved access and health insurance coverage through the Medi-Cal expansion is actually translating into improved health for Californians. So this is encouraging evidence that the policy change is doing what we hope, not only in giving health insurance, but that it's actually benefiting people's health. On the other hand, we are finding ongoing disparities, particularly health insurance coverage and access, such as usual source of care by race, ethnicity. And these issues may require more targeted policy changes. It could be additional support, such as navigators to help people who are eligible actually enroll in a plan. And it could also be thinking about outreach for different languages or, different methods of outreach, but that all kind of takes actually making some of the policy being that targeted support to help people move from eligibility into enrollment. And here's my contact info if you have any questions, and I will move on to hearing Scott's response. Looking forward to hearing more about the California policy story.
And this is Leonore. Thank you so much, Natalie, appreciate it. So just real short about Scott. He's been working for the legislature since 1993. He started his career as an Assembly Fellow and has worked for the Assembly Speaker, the Senate Health and Assembly Appropriations Committee. He is currently a principal consultant to the Assembly Health Committee. He analyzes legislation affecting public programs in California, such as the Medi-Cal program. And he's worked on a number of healthcare issues, including implementing the Affordable Care Act in California, and including this very expansion that we're talking about. So he's really been around. He knows how the sausage is made, so to speak, but also he can sort of give us a perspective as to, what were policymakers thinking when they implemented this? Is this a surprise? Are Natalie's findings a surprise? What do we still need to work on, et cetera? So thank you so much, Scott, for joining us. Go ahead.
Thank you for having me, and to Natalie for the research. The United States is unique in its healthcare delivery system. Among industrialized nations, we have a multiple payer system, which leads to complexity in administration and eligibility and payment. Prior to the implementation of the Affordable Care Act, Medi-Cal provided coverage to adults, but it was limited to people who were low income, meaning they had to be low income and disabled, or low income and have children, or be low income and be pregnant. But if you were just low income and not disabled, you were not eligible for Medi-Cal coverage. And so what the ACA did is in 2 things, is it increased the parental eligibility to 138% of the poverty level. Prior to that, it was 100%, but really a little bit higher because of the way we counted income. And it made single adults without minor children eligible for Medi-Cal who were under age 65. This was a significant change. And why the study is important, I'm going to highlight what I think are three important reasons. The first is coverage matters. It matters for improving health, for providing access to care, for protecting against financial loss. Medi-Cal is not a perfect program. The results are not clear cut across populations, that disparities continue to exist, but the results are positive. And fundamentally, uninsured adults have less access to recommended care. They have poor quality of care. They experience worse health outcomes than uninsured adults do. There's a prominent consumer advocate who uses this line that's kind of paraphrasing from the Institute of Medicine. People who are uninsured live sicker, die younger, and are one health emergency from financial ruin. And that line has always stayed with me. The second issue that to highlight is this issue is important because the Medicaid expansion is still an issue nationally and in other states. The study notes that 14 other states have still not implemented the expansion, including 2 large states, Texas and Florida. The Supreme Court decision, which was otherwise positive in upholding the law, did make the expansion an option, which was somewhat of a surprise to a lot of people who were following the case. States continue to debate whether to expand coverage. There isn't a consensus in the United States on the obligation of state government, the federal government, to provide care to low-income people or to have universal access or universal delivery system. If you're interested, there's a MANAT, which is a consulting firm webinar on assessing the fiscal impact of Medicaid expansion in Mississippi that I just got an email on in the last week. So states continue to look at this, but they look at it in terms of what it means for their state residents and the availability of federal funding and the availability of coverage. Obviously, ACA repeal was a prominent position leading all the way up to and through the election of President Trump. The program was proposed for repeal and Medicaid was proposed for block granting. And we remember coming back from campaigns in 2016 following the election and realizing we could have a pretty significant problem here. And if it weren't for John McCain and kind of the thumbs down in July 2017, the best thumbs down I've seen since a Gladiator movie, we wouldn't be here talking about this today. We would probably be talking about how to preserve coverage gains that were enacted pre-ACA and how to ensure coverage. I think the third and final reason that this is important to know is there's a notion that kind of California can do with this alone, that the state has a strong commitment to universal coverage or universal access at least, that California was a leader, that legislators and the governor and the current governor embraced the expansion. But really, I can't understate the importance of the federal funds and making the expansion a viable and doable thing. I started with the legislature in '93. It was always a longstanding legislative policy goal of expanding coverage to the uninsured. Previous estimates from around 2010 through 2012 were that 21% of Californians under age 65 didn't have coverage. 7 million Californians didn't have coverage. We were the 7th largest state, or 7th ranking state in the percentage of population who were uninsured. And the issue was always funding. And now, as a result of the optional expansion, as we call it, the ACA expansion, California has over 4 million people in the option expansion, 4.1 million in the current year, expanding to 4.7 in the budget year. They are matched at a 90 to 10 funding rate, meaning the federal government for every dollar that is spent on this population provides 90 cents for the benefit costs and the state provides 10 cents. In terms of state dollars, that means 23 billion in federal funds in 21-22. To put that number in context, the total general fund spending that we put into Medicaid is 26.8 billion. So the amount of federal funds that we get just for this population almost matches the amount of general fund the state puts into the Medicaid program. So if the program is the Medicaid expansion were to go away, we would have at least a $23 billion hole, increasing to $26.5 billion in the following fiscal year. To put those numbers further in context, spending in higher education in California for UC, CSU, community colleges is $18.5 billion. To put it further in context, spending on the Department of Justice, courts, and corrections is $14.9 billion. So this is a massive infusion of federal funds that made the expansion a viable thing. It's also important to realize that the expansion doesn't occur unless policymakers make this a priority. When Governor Brown was sworn into office, he faced multi-billion-dollar deficits and what was termed the wall of debt. And for a while, we were unsure if they were going to embrace the expansion at the legislative staff level. We didn't, their public embracing of the expansion didn't come out until January of 2013. And then we worked on the bill and it became part of the budget trailer bill process. Trailer bills are bills to implement the state budget process. And really, credit goes to the governor, who, once they did decide to embrace it, they were all in. We took advantage of all of the flexibilities just about that were authorized by the ACA. The expansion was embraced, covered California, and Medi-Cal did outreach and extensive marketing. My then boss, Senator Hernandez, and then Speaker John Perez were the legislative leaders on this, also Darrell Steinberg. And at the staff level, really to shout out to Toby Douglas at DHCS, Diane Van Maren from Senate Budget, Agnes Lee in the Speaker's office, and Marjorie Swartz. They did a ton of work on this in a very compressed time frame to get this enacted by June, and then leading into the implementation of July 1st. There were a number of other changes that made enrolling in the program simpler and easier. The asset test, which is a limitation on the amount of money you can have in a bank, which have not been adjusted since the 1980s, were repealed for the expansion population, so you no longer had an asset test. And also, we made it easier to stay on the Medi-Cal program. We used to do things to achieve budget savings, to make people turn in paperwork more frequently to show that they continued to be eligible for coverage. The ACA said you couldn't do that anymore. So the results, the study is encouraging. The disparities continue to persist and are troubling and should be addressed, and are going to be an ongoing discussion of legislative and executive branch action. There are additional expansions proposed on the remaining uninsured. California's uninsured rate is estimated somewhere between 9.5 and 7%, about 3.2 million people. The overwhelming percentage of the 3.2 million, around 65%, are undocumented adults. They are proposed for a full expansion of coverage through the Medicaid program as part of the governor's budget, phased in over the next couple years. So the number of people who are going to be covered through either federal subsidies, the Medicaid program, job-based coverage, individual coverage, is likely to increase, and the number of uninsured is likely to continue to decrease. So I think I'll stop there to leave time for questions, but thank you for having me, and I appreciate Natalie for doing the work and the research.
Thank you so much, Scott. Appreciate it. So please submit your questions. My colleague, Amber Carlisle, and I, she's the director of one of those wonderful fellowship programs that I mentioned. She's director of the Assembly Fellowship Program, where Scott started his career many years ago. We will be curating and collecting your questions. And before we launch into the question, I just wanted to ask Scott, in terms of your reaction, were you surprised? You were involved in this expansion. You saw it sort of from its seed level to grow to, the multi-billion-dollar expansion and this thing that benefits millions of Californians. Are you surprised by Natalie's results?
No, I do think, there's a pretty extensive body of literature dating back many years that coverage does matter, and it matters for multiple reasons. It matters for access to care, it matters for mental health and financial security, And so I do think it's consistent with prior research. I do think it's important to restate because there is pretty regular criticism of the Medicaid program over time as not providing access or comparable health to coverage or to the lack of coverage that the uninsured have. That and there's continued controversy over whether the program should be expanded and whether services should be available through the program to low-income populations who would otherwise not have coverage.
Wonderful, thank you, Scott. Our next question is, since the expansion of Medi-Cal, have you seen a significant decrease in other types of spending, for example, incarceration and emergency services?
I'm not familiar enough with incarceration data to know. There has been an effort to make sure that people who are incarcerated have coverage upon leaving incarceration. There's a high risk for overdose and poor health outcomes and the trauma that a person would experience from being incarcerated. So there's been a push to link people. This isn't answering the question. There hasn't been a decrease in emergency use utilization. Medicaid, people on Medi-Cal are more likely to use the emergency room than if you look at users of the emergency room as a percentage of the population. I think that's a function of several things. One is the emergency room is an expensive location for people with private coverage to receive care, and there isn't cost sharing available or there isn't cost sharing that's charged to Medi-Cal beneficiaries. So there isn't the same financial deterrent to going to an emergency room. There isn't balanced billing. There isn't balanced billing anymore in California, but at least for people with state regulated plans and now federally regulated plans. But there isn't the same deterrent to going to the emergency room as there exists for people with private coverage. And last, if people are going to the emergency room, it is potentially a flag for access in the program. And one of the areas that Medi-Cal, if you ask Medicaid beneficiaries about where there are problematic areas, one of the things that's cited is access to specialist care and to mental health. And so that may be in part why there may be greater use of the emergency room, but it's not something that I've read recent literature on it. Maybe Natalie has more that she can add on it.
Yeah, I think my answer would be similar. The incarcerated question is interesting, but kind of harder to get data, although there's probably a little bit of opportunity for that. And the ER visits, it's like, yes, we would hope that people would use primary care or that type of thing, but many studies do find, yeah, with public coverage, you might actually use the emergency room more than uninsured. So I agree with that. I think there's been some studies I found interesting where they try to look a little bit at changes over time. I think it was for the homeless population actually, where they find an initial increase, but then after a little bit period of time, you maybe start to see a different pattern. So I think being able to look longer term, which is more challenging to find the data, but that could tell an interesting story about how people's use of the emergency room, it might actually, we might be seeing improvements if we could look longer term. But then it kind of relates to as well, just the structure of care. And as important as having coverage is, it's also like, how do you get people to, be able to go to regular visits and have a relationship with their primary care, which then hopefully that would also decrease the ER visits in the long term. So there's kind of like the deeper questions about the quality of care as well. So kind of, it might take a few more steps to impact the ER visits, whether it's looking longer term or taking additional steps to help people engage with the system.
Thank you. So Dr. Schwehr, there's a question about your research and the multivariate results and why they were limited to childless adults.
Mm-hmm. So first of all, many of them are limited to childless adults. The first column was for all adults. And the reason that we're limiting it to childless adults was based on basically previous research and also fitting with our findings of seeing a bit stronger results sometimes for the childless adults, which fits with the policy change as kind of talked about where before the Medicaid expansion, people who had, parents or disability already had some eligibility. So the expansion was extending eligibility to childless adults who previously didn't have eligibility.
Thank you. Our next question is, could you discuss why the racial disparity in coverage still persists?
Yeah, I think that's complex, but something we should all continue to think about. And there's certainly relates to general social factors in coverage and how that correlates with race, ethnicity. And then, with race, ethnicity, we would also want to think about systemic racism and just the full range of barriers that people might be facing regarding healthcare and healthcare coverage.
Scott, any thoughts on that?
No, it persists for multiple, it's problematic and it persists in mental health, for cancer care, for maternity coverage, for access to pain medication. There are legislative efforts underway kind of outside the Medicaid space and within the Medicaid space to try to address disparities through better public reporting, continuing education. But the problem exists both within Medicaid and within the larger healthcare delivery system.
As well as in education and many other segments, unfortunately. Okay, so we have a question about college students. So is there any opportunity to allow uninsured or Medi-Cal eligible college students to be covered under regular Medi-Cal rather than like an HMO via the county coverage? That's not very portable for college students who move around a lot. Or is there any consideration for having Medi-Cal pay for college health insurance premiums for university health insurance programs?
We had a hearing on this when I worked for Dr. Hernandez, who was the author of the ACA bill on the Senate side. And the question is correct in that the system we have now is county-based for Medi-Cal. So you'll have a plan that is specific for your county or your region. And for college students who move from one area of the state to another area of the state or out of state to attend coverage, the system does not work well. You have access to emergency services and urgent care out of network when you're away at college. The process to enroll in switch counties through the inter-county transfer process and to re-enroll in a plan doesn't work well. The University of California did express interest in doing a what's called premium assistance program, where the state would buy their SHIP coverage for college students who are Medicaid eligible, and they have over 20,000 this was several years ago, students who are on Medi-Cal who attend the university. But there are multiple issues associated with this. One is that students are increasingly obligated to have insurance coverage as a condition of attending colleges and universities. And universities make available health insurance, but often the student has health insurance through their parents' coverage as a dependent, which now goes to age 26 under the ACA. But the universities want the coverage to be available and accessible to the student. So the parents' coverage, which may be, if the parent is in Sacramento, but the child is attending, for example, UCSD or San Diego State, that plan may not exist in that county. And so the coverage may not be available there. So the students or the student's parents have to pay for coverage out of pocket and or buy the student health plan. And then they pay a separate fee typically for access to the student health center. And that student health center may not take insurance. So the system is not real well designed for college students. We have talked internally about having someone take this on and try to figure out a better way to do it, because you have parents who are paying for who may have access to coverage through their work and have their child on as a dependent, which now goes through age 26. But when the child goes away, their insurance is not viable for them. And that's true of Medi-Cal. So I do think that's something that needs to be looked at. But I don't know that anybody's doing a bill on it. There was a Senate Office of Research report on this topic that was really well done. So if anybody else has anything to add on it, I'll stop there.
Yeah, I don't really have much to add, just that it's interesting how the ACA did try to help college students with the dependent care so they could be on their parents' insurance. But this question is a great example of how that still doesn't help everyone, whether it's for these kind of geographic issues or students whose parents might not have coverage that they could use. So it's like a step forward, but more is needed.
Thank you. Returning to the topic of racial disparities, the paper mentions that targeted legislation is needed to address those concerns. Could you talk about what some of those proposed legislation would be? And Scott, could you talk about anything under consideration in California currently to address the existing racial disparities?
I mean, I guess I would just say I think the proposals I've been reading about to remove immigration status as a barrier seems very groundbreaking and could, be a really meaningful change for helping to address some of those disparities. Especially exciting since other states aren't doing it.
There was legislation enacted last year that was referred to as the Momnibus bill to address disparate treatment that African-American women who are pregnant experience related to birth outcomes. I wasn't the analyst who worked on the bill, so I'm not super, other than a provision that included coverage of doulas as a way of improving the birth outcomes of women. There is also public reporting on disparities in a way to highlight the issue. There's been multiple pieces of legislation on that, and the issue continues to be highlighted in the reviews that are done of the state's managed care system for mental health and substance use disorder treatment. If you look at the population who is receiving services, there's wide gaps in mental health treatment and prevalence and suicide rates by region and by race and by gender and by age. So that it's an ongoing topic. We're in the first year of, or the second year of a 2-year session, and not many bills have been introduced today, but I know there will be bills introduced on this topic. The deadline to introduce new bills is, I think, around February 20th. And so I would expect multiple pieces of legislation on this topic.
Thank you. We have a couple more questions. One is about mental health and access to mental health services. We have someone who is in the audience anonymously saying they are in Medi-Cal and have been having a hard time finding therapy due to most practices no longer accepting new patients. Is that because of the times we are now in, or is there a way Medi-Cal can expand options?
So Medi-Cal expanded the scope of, with the Affordable Care Act, expanded the scope of mental health benefits, but we have severe workforce shortages in the behavioral health system across all provider types: social workers, marriage and family therapists, psychologists, and psychiatrists. Increasingly, many mental health professionals don't need to take insurance at all, particularly psychiatrists. I believe the data is somewhere of less than half actually take insurance, and I'm not talking just about Medi-Cal, I'm talking about insurance from anybody. And we have increased mental health needs, a lot associated with the times that we're in, the pandemic and loneliness and isolation and distress over job loss and income loss. If you are having access to care problems, the state has set appointment availability and time and distance standards for mental health treatment. So I would encourage anybody, if you are not able to access care, you have a right to an appointment, to be offered an appointment within 10 10 days, I believe, is the standard for non-urgent, for urgent conditions. And I think it might be 15 for non-urgent, but I should probably look those up for sure. But there are standards that exist for mental health treatment. And if you're not getting appointment availability, there's a Medi-Cal ombudsman that exists that can assist people with complaints, or the Department of Managed Healthcare, if you are in a private health plan, also assists people, and they have similar appointment availability standards for private coverage.
Yeah, I
Okay.
would agree that there's a, of course, part of the issue is what is the workforce available relative to the needs that people have. Another thing that as researchers we're interested in is, which providers accept Medicaid or not, which does depend somewhat on the specialty, but also, that's something where sometimes we can look across states and, the concern is that the reimbursement rates may be lower for public coverage. And then how does that relate to which providers choose to accept Medicaid? So that's always a concern as well.
Next question. Secretary Becerra recently extended a declaration of a public emergency due to COVID for an additional 90 days. Can you talk about the implications on low-income communities of the declaration of public health emergency, and also the implications for when that emergency period ends?
Yeah,
Natalie,
so this
do you want me to go ahead?
Oh, either way.
Go ahead.
So the public health emergency included a continuous coverage requirement. So this led to increased public coverage. So more people are on Medicaid now than other times historically, as the continuous coverage requirement means that people aren't being dropped from Medicaid like they typically would be sometimes with redetermination. So there is a good amount of concern about what's going to happen with the end of the public health emergency, which that would mean opening up states and Medicaid to do redeterminations. So then, for example, basically the working poor, people who have increased income, but still, limited funds, maybe dropped from Medicaid and not have other support. And this could be have a negative impact, especially on different vulnerable populations, low income generally, but as well as people of color who face disproportionate impacts with the pandemic. So for now, it's been extended another 90 days, but it's definitely a concern how to what's going to happen when it ends, and how to not sort of take a step back in terms of the benefits that we're seeing with the expanded Medicaid due to the public health emergency.
To add to what Natalie has said, the state has instructed counties not to take what they call negative actions to remove people from coverage. So on the natural, around 100,000 people, 150,000 people each month leave the Medi-Cal program because of redeterminations, which is the annual process by which a person has to continue to show that they're income eligible for the program. People also leave the program when they have time-limited coverage that ends. For example, coverage following a pregnancy goes to 60 days postpartum. During the public health emergency, the leaving of the program has been paused, except for three reasons. If the person died, obviously, if they moved out of state, or if they requested to be disenrolled. So there is going to be a lot of work for county eligibility workers who do the Medi-Cal eligibility determinations on behalf of the state when the public health emergency ends, to do all of these redeterminations that have been paused for what is now, I don't know, over 2 years, I think. The second big impact it will have is the state gets an enhanced Medicaid matching rate during the public health emergency. And it's been over billions of, for California, it's been over $1 billion. I don't know the exact figures. And so it's a twofold impact. It's an impact on people, it's an impact on the state budget, and it's an impact on counties that administer the program, that administer the eligibility process.
So thank you so much to everyone. Are there any final comments that either of you have or questions that you'd like to pose or anything? No?
Thank you for doing this.
Yeah, thank you so much to Natalie, I'm sorry.
Oh, I was to say thank you, and just it was really neat to hear some of the kind of the backstory with the ACA and how, you know, it took a minute even for California to be on board, which is such a leader nationally relative to a lot of these more progressive health policies. So appreciate hearing the stories.
Well, it's good to know that it had a positive impact. And thank you so much, Dr. Natalie Schwehr, for all of your wonderful work, your research. Thank you, Scott Bain, for lending sort of a real world perspective to how this actually happened and the thinking behind it. Thank you, Ted Lasher, for leading the editorial process on CJPP. Thank you, Amber, for helping with the questions. And thank you, Rotzi, for producing this. And thank you, Sac State, our home, and my colleagues at the Center for California Studies. And this recording will be available, will be sent to you as you've been attending. It will also be available on our website at a later date. Thank you. Also, please fill out our survey. It's in the chat box.